Welcome. We are so pleased you can join us for our virtual community gathering. The stories you will hear today will help us understand some of the many challenges in healthcare that patients, their families, and healthcare professionals are experiencing. We will learn how the OHSU Center for Ethics is expanding to better meet these needs and help make healthcare a more humanizing experience for everyone. The first person I'm delighted to introduce you to is Dr. Stephen Post, Director of the Center for Medical Humanities, Compassionate Care, and Bioethics at Stony Brook University. He will briefly describe how the OHSU Center for Ethics is unique in the nation.
OHSU's Center for Ethics and Healthcare is, in my mind, number one in the United States and possibly in all the world. That sounds like hyperbole, but it's not. The reason why the center stands out so beautifully is because of its humility. Humility means that you are really trying to serve the identifiable constituencies of the state. You know, there are good people in every city and every town and every little hamlet and farm community across your beautiful Oregon. And you take them seriously. You let them know that their voices matter to you. You're not on high trying to download some philosophical principle, but you're attentively listening, which is the core element of empathy. You're trying to begin at that grassroots level, and you always have, thanks to Susan Toll, who's been so successful with the Post forms, which again originated in that context and have now spread all over the country. Well, no one could have thought about such an instrument without the help of your center, because it's your center that really understood deeply what people needed and what people wanted.
One of the biggest challenges in healthcare is giving bad news to a patient or their loved one. Jill's story is difficult to hear, but it reinforces why it is so essential that all healthcare professionals learn the skills they need to give bad news with compassion and respect.
Ben was kind of amazing, actually. He was unique. We were married for 22 years. We made this other person that was just kind of wonderful. Losing Ben was losing my grip on life. Ben was slowly going into dementia. He fell in the bedroom at 4:30 in the morning. So they took him to the hospital, and the doctor tells me that Ben is not going to make it, that it's terminal. And that doctor, bless his heart, was honest, direct, straightforward. And I'm so grateful for him to do that, because I could make an actual honest decision. And I did. I loved him so much. And I said, comfort measures only. And then I said, how long? What's the prognosis here? And he said 2, maybe 3 days. I stayed there with Ben for a while. And I told him, I said, look, I'm going home for a while. I'll be back later. If I can't get back here later, I will be back here in the morning. And you be here, okay? I came home to get the paperwork filled out and signed and all that. And the phone rang. I answered it, and it was a man, voice I didn't recognize. He said, well, I'm Dr. So-and-so, and I've been tasked with calling to tell you that your husband passed. And I heard that, and it kind of went through, and I said, no, he had 2 days. And I said, no, what do you mean he's dead? He said, yes, he's dead, and I'm very sorry about that. If you would like, he put on his compassionate voice. He said, if you would like, you could come up and sit with him for a couple of hours, sit with his body. And I said, I don't think I could. I said, I don't think I could drive. And then I started feeling guilty because I'm not going up there to sit with his body. When he said he had been tasked to call and tell me my husband had passed, was, you were given a task? This is a task? No, it's not a task. It's the rest of my life. I'm not angry with that doctor. Don't get that impression. I'm not at all. He sounded uncomfortable. He didn't want to do that. And I can understand that. And it's not his fault. He just wasn't trained.
Honestly, I'm just heartbroken to hear that this was Jill's experience, that this life-changing moment for her had to happen in this really traumatic way. I am equally heartbroken for the resident that was put in this terrible situation. It's an impossible situation. You're being asked to do one of the hardest things in medicine. You're being asked to go cause trauma to another human being, and you haven't been properly trained or supported to do it.
Patient-centered communication, meaning putting the patient's communication needs first, is really important during all medical encounters. But it's especially important when the information being shared is bad news. Now, sharing bad news with patients is stressful for patients, but it's also stressful for the clinician. And sometimes when clinicians are under additional stresses, such as feeling overworked or feeling underprepared, as likely occurred in Jill's case, they may fall back on less patient-centered communication habits. What we're doing with our medical students then is trying to teach really strong habits that are patient-centered and sensitive, so that when times are difficult, that's what they fall back on.
Since 2018, we've been testing every single medical student at OHSU in compassionate communication on how to deliver serious news like your loved one has died. So here at OHSU, we are ensuring that our medical students can walk out of their medical school training and be prepared to have this type of conversation. Unfortunately, Jill's story shows us that there still is quite a bit that needs to be done to make sure that this experience doesn't happen to someone else again in the future. Here at OHSU, each year, we have a whole new group of residents who join us from across the country. Some have been trained in compassionate communication, many others have not.
Delivering bad news to a patient or a family member is one of the hardest jobs that a physician has, especially a young resident physician early in their training and who doesn't have much experience. When you know you're going to walk into a room or pick up a phone and what you have to say might drastically change someone's life forever, it's incredibly challenging. I know for myself, I didn't come to residency with any sort of training or practice. Had to fumble my way through it, trial and error. And I don't think any physician desires to do this poorly, but it takes training and skill and some practice to be able to handle these conversations with the compassion, gentleness, and care that they so deserve, to really honor our patients and their family members, and also for our own wellness, that we can take care of ourselves as we navigate these difficult conversations.
Jill's experience is happening in communities all across Oregon. And my ultimate vision is that we are able to help touch faculty and trainees that reach every corner of Oregon, so that all Oregonians are afforded compassionate communication when they interact with the healthcare system.
The Pulse program has dramatically improved end-of-life care in Oregon. However, we know there is still more work that needs to be done, as we occasionally encounter situations where Pulse isn't honored. Johanna's experience tells us how painful that is when it happens.
Peter. He was so adventuresome. He was so in the moment. He was a magnet. And I was attracted to his spontaneity, his sense of humor, his love of life, his love of family through the 45 years that we had together. About 10 years ago, Peter was diagnosed with mild cognitive impairment. That was fine for a couple of years until it was clear that mild cognitive impairment started feeling less mild. I was devastated. I was just devastated. But it was 100% clear that Peter never wanted to prolong his life in any way, shape, or form. As Peter's disease progressed, the doctor suggested that we might want to consider creating a pulse for Peter. That seemed like a really great idea because I wanted the medical establishment to also understand that Peter wanted no ways of extending his life. It was important for me to know that Peter had a pulse because it created peace of mind for me and documented his wishes. In January of this year, Peter fell and broke his hip. Because it would be painful not to have hip surgery, I went ahead and authorized the surgery. Prior to Peter having the surgery, I got numerous calls about questioning what interventions should happen. Multiple calls, the surgeon, the anesthesiologist, the ER doc. And each time I felt like there was a question about what the actual pulse said. It was difficult to answer those questions because in every case the answer was no. We didn't want any extraordinary measures. He didn't want extraordinary measures. That conversation was exacerbated the next day by the hospitalist, who was so intent on blood work, catheter, etc. when Peter spiked a fever. She was absolutely not respectful of Peter's wishes, and I ended up feeling like an axe murderer by the time all these questions were asked and answered in the negative. It was horrifying. I had hoped that the pulse was the definitive understanding between a patient and their medical care. If it's not, what else does there need to be?
Hearing Johanna and Peter's story makes your heart drop. It is tremendously disappointing to hear what Johanna went through. Though Pulse has helped many people, sadly, there are stories like Johanna's. And indeed, it is stories like hers that emphasize the need to remain vigilant about how Pulse is functioning and in what ways it could be going awry. In this particular situation, there are two main approaches to address the problem. The first is that documentation about Pulse and Pulse forms need to be readily accessible and easily visible to clinicians. It is crucial that healthcare professionals can find those Pulse forms and can find documentation about serious illness conversations with ease. The second is to address the education and training needs. Healthcare professionals need to be able to trust that a pulse reflects a thoughtful and caring conversation with a patient, a conversation that can be built upon and not second-guessed.
The majority of the training around how to use a pulsed form really comes at the very beginning, when we're taking an individual's goals and preferences and we're weaving that in together with the medical complexity, that's when the pulsed form is created. Where we really don't have a lot of training yet is around what to do with that pulsed form, how to interpret and make that pulsed form come alive in a moment of crisis. One, we need better education around what pulsed is and the process that people go through to make these values-based decisions. And we also need to empower doctors and clinicians with the communication skills to be able to really pull out those values and understand how and why these decisions were made.
One of the main focuses of improvement efforts right now is to improve the accessibility of PULSed. With that in mind, we're translating PULSed into 14 different languages.
When we're adapting the PULSed into different languages, it's so important that we do not do a straight translation from the dominant English language culture material. We need to adapt those materials to the culture and the language of each of the communities that we're translating for. And a key component of that is to get input from the community members to help us make sure that we're communicating effectively and that we're communicating respectfully and that we're honoring people's dignity.
PULSed started in Oregon. Now, most states in our country have a PULSed program, and it has spread internationally. We remain dedicated to being leaders in PULSed, and being a leader in PULSed means you take a story like Johanna and Peter's and you learn from it. You learn where you need to direct your improvement efforts and how you need to innovate, so that the next time there is a Johanna and a Peter, they have a different experience.
The Center for Ethics is delighted to welcome Dr. Maureen Kelly, the Madeline Brill Nelson Chair in Ethics Education. After a brief introduction from Dr. Toll, Dr. Kelly will describe how healthcare teams must work together to help vulnerable patients like Charlie.
The Center for Ethics welcomes Dr. Maureen Kelly as the new Madeline Brill Nelson Chair in Ethics Education. We did an international search for this position, looking at her teaching at the University of Oxford, prior to that, the University of Washington, prior to that at Baylor. She is much more than an outstanding educator. She's an internationally recognized researcher. She has served on the World Health Organization Ethics Committee. She conducts a wide range of research, including topics that are stigmatizing in vulnerable populations and how those populations want to receive messages. We welcome Dr. Kelly from the University of Oxford across the pond to OHSU.
Medical ethics training, support, and research are powerful tools for addressing critical health inequities faced by so many patients and families living on the margins. My own passion is to figure out how to offer the highest standard of care for every patient, no matter their background or circumstances. As you've heard from my colleagues, patients and families have so much to teach us about how to provide compassionate and inclusive care. One patient I'll never forget was a young boy named Charlie. When Charlie came into our hospital's care, he had already experienced an incredibly difficult life. Charlie had never known his father and had been placed in foster care at age 3 when his mother lost custody. Sadly, when he was 7, Charlie was diagnosed with leukemia. His foster parents helped him through treatment, staying by his side at the hospital. He responded really well, and his cancer went into remission. Charlie attended school, but was soon placed in a new foster home. By the time Charlie turned 10, he had been in and out of 4 foster homes across 2 states. He had run away several times until being placed in his current group home. Lately, Charlie had been having dizzy spells and aching pains in his arms and legs. The group home manager grew worried and brought Charlie to the hospital. His blood work and x-rays came back with terrible news. His cancer had returned. Charlie's type of leukemia, even when it recurs, can respond well to treatment, but it wouldn't be easy. He would need chemotherapy and another bone marrow transplant. He would have to take medication strictly every day to stop his body from rejecting the transplant. The team worried about how they would get him through treatment and follow-up care without family to help, especially given Charlie's difficult behavior. One night, he had had a bad dream and smashed his hospital window trying to escape. Later, during playtime, he shoved another patient when he tried to take Charlie's video game, his only toy. One doctor said, "I can't in good conscience cause a child pain and suffering with chemotherapy if I know he doesn't have the family support to succeed. Aren't we just adding more suffering to Charlie's life?" But we all knew without treatment, Charlie would die. When I met Charlie, I saw an old soul looking out from a 10-year-old's face. He was really bright and curious, asking lots of questions. He knew he was sick and he wanted to feel better. He understood the medicine for cancer could make him feel really bad in order to get better, but he wanted to try. He said he was sorry for misbehaving and asked if he could stay with the other kids on the cancer unit if he promised to be good. He didn't want to go back to the group home because the other boys bullied him. "They hold me down and they take my stuff," he said. "I yell or hit them first, so they leave me alone." Charlie's lashing out about the video game suddenly made perfect sense. When kids like Charlie get sick, medical teams depend on a range of adults to advocate for their care: judges, guardians, foster parents, and social workers. But the state child protective system is underfunded and overwhelmed. Caseworkers are responsible for too many kids and stretched too thin. They can't be a constant presence at the bedside as parents would be. Good parents are fierce advocates for their children when they get sick. In pediatrics, we sometimes call a super protective parent a mama bear. And as anyone in the Pacific Northwest knows, you don't cross a bear and her cub. Charlie brought out the mama bear in all of us. We agreed that Charlie deserved every chance at survival. We just needed to figure out a way. There was an amazing psychiatric nurse who was a real champion for Charlie. She helped the cancer team understand how to care for a traumatized child to avoid triggering him. The transplant team worked late hours and found a bone marrow donor. A social worker was on the phone around the clock trying to find Charlie a new foster home. Several of us testified to the judge requesting an urgent placement. One of the nurses volunteered to foster him in her own home during his treatment until a family could be found. It was a long road, but Charlie responded well to treatment and soon came out of his shell. He was funny and smart and loved giving hugs. He was a total whiz at video games. The team grew really fond of him. On his last day of chemo, before his transplant, some great news. They found a new foster family. Charlie's new foster mom came to meet him and the team. She held his hand and said, "I can see you're a fighter, Charlie. We're going to be here as long as you need us." There are too many kids like Charlie the world over who have lost or been separated from their parents and family. Sometimes they've lost parents to illness, such as HIV/AIDS, or natural disaster like the earthquake in Haiti. Other times, children get separated while fleeing from wars or poverty. Some are escaping abuse and neglect in their own homes. These kids get sick. They need preventive care and childhood vaccines. They need management of chronic conditions like diabetes. They need glasses and hearing aids. They may have autism or other learning challenges that go undiagnosed, which means they lose out on critical early childhood development. They get appendicitis, pneumonia, COVID, and like Charlie, they get cancer. Their invisibility means too often they fall between the cracks, and lack of access to healthcare can have a ripple effect throughout the rest of their lives. They need us to advocate for better care. They need us to hear their stories and be by their side. Charlie taught us what it takes to earn a traumatized child's trust and the importance of meeting them where they are. He showed us true bravery and resilience, and he brought out creativity, love, and hope on the team. Most of all, he taught us the importance of approaching our patients and families with humility as learners, not teachers. We have so much to learn about their experiences and how to be better advocates for their care. I still think about Charlie, and I wonder how he's doing. He taught me that all kids deserve a fighting chance and someone to fight for them as a parent would, especially if they've had a rough start in life.
Accessing healthcare can be challenging for many of us. It is especially challenging for those who struggle with disabilities. Next, Dr. Susan Toll, the Cornelia Hayes Stevens Chair of the Center for Ethics, will share a very personal story to help us understand the changes that need to happen to humanize healthcare for everyone.
My brother Ron died earlier this year. He had closely followed our work in the program in compassionate communication and very much admired Dr. Ron Nato as a mentor in serious illness communication. He was a very private person, but he asked that I share his story so that people with autism and people with severe anxiety would have a more welcoming experience in healthcare. A cousin referred to Ron as wicked smart, and he was. In middle school, he read every volume of Encyclopedia Britannica and every issue of National Geographic back to 1920. But being genius level smart wasn't enough to navigate healthcare. Being in a COVID line to get a shot, people close to him, conversations, some of which were distressing to him, confusing messages led to a sense of overstimulation, extreme anxiety, and a desire to flee. But it doesn't have to be like that. At a private dental office, the hygienist turned off the background music, avoided lightly brushing against him, always told him when she was going to touch him, and he was able to get his teeth cleaned. But the dental clinic couldn't accommodate his appeal for a more abbreviated informed consent process. And he still got the whole list of possible risk for procedures, including 1 in 10,000 risk of death from anesthesia. The same overstimulation, anxiety, desire to flee. Cliff Coleman is helping us design a way where we can meet each patient where they are.
We've been teaching the golden rule for years, but are now realizing that that's really not enough. For me to apply the golden rule means that I have to assume that you're the same as I am, that you have the same values, the same beliefs, goals, and preferences as I do. And that's just clearly not the case. We are all the products of a rich combination of cultural influences and experiences, including things like autism in Ron's case. And instead of the golden rule, we are now teaching what we call the platinum rule. That is, learn to treat people the way they want to be treated, which requires cultural humility and an openness to other people's perspectives. The platinum rule really requires that we learn how to set aside our assumptions, our judgments, our biases, and really listen to and understand each unique individual in our care.
What Cliff is talking about is truly a profound change in healthcare. We will have to use clear language and empower patients to be more effective partners. We will have to deal with the hierarchy in medicine. There will be systems changes that will be needed. And of course, there will be education. This is a heavy lift. But we know how to do it. We do it in the Living with Life-Threatening Illness class. We do it through the eyes of our patient teachers. and our colleagues in hospice and palliative care and geriatrics know how to meet patients where they are. We can and we must change.
OHSU's Living with Life-Threatening Illness course is so popular that it is oversubscribed every year. The impact of the lessons taught stay with the students long into their medical practice. Next, we'll hear from Dr. Tyler Tate, Director of Professionalism and Comfort Care, along with a few of his students and an alumna of the School of Medicine.
There are a variety of challenges that clinicians face today in modern healthcare systems. We're always pressed for time. There's a computer screen that is constantly coveting our attention. And what we have to learn to do is to overcome those challenges and to do so in a way that keeps the patient at the center of every conversation, and yet also allows clinicians, allows doctors like myself to feel human. There are numerous things that make Living with Life-Threatening Illness course especially unique. One major thing that sets it apart is that unlike most classes where you're just in a classroom talking to students, in this course, every student is paired with a real patient who is themselves living with a life-threatening illness. And over the course of 9 weeks, these students meet with their patient teachers, as we call them, to discuss a variety of issues of what it's like to actually live with a life-threatening illness. The patient teachers teach the students so much about what it's like to be a compassionate, thoughtful physician who gives respect no matter what the circumstances. And there's just almost nothing else like it. It's a transformative process for me, and I'm really grateful that I can participate in it. I'm a palliative care doctor. I'm also an ethicist. So I think a lot about what I would want students to become as they step away from this class and enter into the rest of their clinical lives. There are 3 real attributes that I think are critical for future clinicians that we talk a lot about. Those are compassion, humility, and courage. You know, it's a big focus of our center coming forward in the future is moral courage. And this is something I talk to my students about. You can't just know the right thing to do. You have to have the courage to actually do it, even when the stakes are high and the cost is great.
I think the greatest impact that this course has had on shaping me as a future physician is to truly be able to silence my inner voice and listen to my patient and what they really need. I think it's easy to try to make assumptions for patients, but in this most sensitive time of their life, the most important thing for me to be is a sounding board for them and give them whatever support that they need. And this course has truly shaped me to do that.
I took the Living with Life-Threatening Illness class in the second year of my medical school, which was about 14 or 15 years ago. The class was wonderful preparation for getting to speak with patients about their diagnoses and preparing for end of life, because it allowed the students to be able to really ask the questions ahead of time, practice what they were going to say, maybe even how they were going to say it, and to get feedback from the rest of the team. I know for a fact that my practice is richer, my experience with patients is richer, and what I take home from my work is richer because I've allowed myself the opportunity to open up and learn these kinds of communication techniques with patients.
This course has certainly already changed how I treat and approach patients in my very, very short clinical career so far. And I can say, to put it simply, when I go into an ICU room and I'm treating a surgical patient, I feel that tendency and that draw to identify all these different body systems and variables to optimize and connections to make, and all these complex things. And then because of this course, I have a gnawing sense that I need to step back and recognize this is a father, a brother, a son, a daughter, etc., that this is someone who's defined by their interactions with others. not their interacting organ systems, not the problems that they have that brought them in the hospital. So I would say this truly has revolutionized the way that I really see the person in front of me when I come into a room.
Medical humanism says that at the center of all healthcare and medical practices is a human being. It's not a machine, it's not a computer. It is a human being that needs to be focused on. And so, what does that mean? To help answer that question, we have built a speaker series that we're growing and developing, something that we've run the last year called the Oregon Bioethics and Humanities Colloquium, where we've brought in experts in a variety of fields, things such as race and racism in healthcare, disability in healthcare. How can we maintain the dignity and respect of a person no matter what their ability or disabilities may be? It's really easy to forget that at the end of the day, what patients want is not just to be cared for, but to actually be cared about. Being a patient is incredibly vulnerable. You're sort of left to the whims of people, oftentimes who you don't know. And what you need is people who are going to give you the care, attention, and respect that will help you feel whole, help you feel safe, and help you feel cared about. That's how you build trust, and that's how you ultimately build good medical care.
We've heard some difficult stories today about the problems in healthcare. Dr. Toll will now share what the Center for Ethics is doing to respond to make healthcare better for everyone.
The programs of the Center for Ethics in Healthcare have never been more needed. Healthcare is under profound stress, and we've shared some problems that we have a strategic plan to address. Your generous support has helped us make a difference, and we intend to move forward in each of the areas. And I would like to share our plan to do so and our gratitude for your generosity. Let's look at the program in compassionate communication and serious illness. We have made enormous headway in the teaching of medical students. Over the past 5 years, we have taught, tested, and for those who needed it, mentored every graduating class. And we have seen enormous progress in their use of clear language, reduced jargon, and compassion in giving bad news. But across our state, in all of our residency and fellowship programs, many of these people have not had the training our medical students have had, and they want it. Thanks to the Storms Family Foundation, we can expand what Katie Stowers and Cliff Coleman can do by adding additional skilled faculty we call coaches to run more training sessions. Thanks to the Kinsman Foundation, we are reaching out around the state to practicing healthcare professionals and helping advance their skills. Together, we're making a difference, and we have plenty of people to train. Now let's look at the PULSE program. About 95% of the time, people who set limits on their PULSE form have their wishes honored. But about 5% of the time, their needs for comfort cannot be met where they are, and they need to be transferred to the hospital. For example, like Peter, they may have a broken bone. And for their comfort, they may need a higher level of care, a trip to the operating room, so that they will be comfortable for the rest of their lives. When they leave the operating room, we have changes we need to make. We need at a systems level to be sure that comfort measures are reinstituted as the patient would want them, and that skilled conversations occur so that family members who have had thoughtful goals of care conversations with their loved one do not feel like they have to defend and carry the burden of judgment from any healthcare professional in wanting to reinstate those comfort measures. We need fewer and fewer people to feel on the defense in assuring that their loved ones' wishes are honored. My brother Ron, I promised him we would do more for people with neurodiversity, for people with anxiety, and really for everyone in meeting them where they are. This is a culture change in healthcare. This means changing the hierarchy, changing systems, changing clear communication and empowering patients to be partners. And yes, it means education. Maureen Kelly inspires us to see the difference that can be made when healthcare leaders come together to advocate for a vulnerable person who can't advocate for themselves. There's a lot of power in synergy, in coming together, in having ethics leaders have more of a concerted, organized voice. We are making a difference in raising the overall skill level of all healthcare professionals in ethics, professionalism, and communication skills. Tyler Tate is launching this new initiative that is just in its infancy by having an academic lecture series that brings leaders at colleges, universities, academic health centers, community hospitals, together to talk about cutting-edge ethical issues, to help educate the next generation of ethics leaders, to not only have the courage to speak out, but the skills to do so effectively, to be able to speak out about injustice and inequity. And we are forever grateful to every one of you that supports us and gives us an independent voice to speak out free of support from healthcare industry sources. I'd like to thank every one of you for what you've made possible in the past, you're making possible now, and we hope you'll make possible in the future. And I am filled with gratitude as we take on each of the challenges ahead.
96% of the center's operating budget comes from private philanthropy. We are incredibly grateful to all those who share our values and are helping us make healthcare a more just, respectful, and compassionate experience for everyone. Thank you so much for joining us.